Hello and welcome. Our work today is in the spirit of moving toward reconciliation and anti-racism through culturally safe care. We'll begin with a land acknowledgement. Canada's treaties and ongoing relationships with Indigenous peoples is a current and ongoing process. As we gather today in this virtual space, we acknowledge and pay respect to the many First Nations, Inuit, and Métis people and their traditional territories on which we live, work, and play. I'm speaking to you today from the traditional land of the people of the Treaty 7 region and the Métis Nation of Alberta. This meeting place is home to many Indigenous people from across Turtle Island, and I'm grateful to have the opportunity to be here with you today. My name is David Braganza. I'm an emergency physician, and I live in Ottawa, but I mostly work in the Francophone and Acadian community of Northern New Brunswick. I also work in rural communities in other provinces, including Ontario and Alberta. I completed my training in family medicine at McGill University and my EM training at the University of Sherbrooke. It is my pleasure to moderate this webinar this afternoon. Our webinar topic was independently conceived by the Scientific Planning Committee, Doctors Eddie Lang, Stacy Kitts, Kirat Griwal, and Peter Iraklius, none of whom had any conflicts of interest to declare. My disclosures are as follows. And these are the disclosures for our speakers today as well. This presentation was made possible by education grants from AstraZeneca, whom I would like to thank for their generosity. All efforts were made to mitigate any potential biases. Our speakers today are Dr. Mitch Shulman and Dr. Sacha Bhinder. Dr. Mitch Shulman is an associate professor in the Department of Emergency Medicine at McGill and an attending physician in the emergency departments for both campuses of the McGill University Health Center. After his undergrad at Harvard, he returned to Montreal to attend McGill Medical School and residency in emergency medicine, where he was the chief resident. He was among the first Royal College certified emergency medicine specialists and served as an examiner for the Royal College. He was acting director of the ED and served as its research director. He's been a community doc and an occupational health physician. Currently, in addition to his emergency department clinical responsibilities, he serves as medical scientist on an ethics review committee and works at the McGill Student Health Center. Dr. Sacha Bhinder is an adult respirologist in the Scarborough area, practicing at the Scarborough Health Network Centenary Site, the Toronto Lung Care Clinic, and the Heart Health Institute. After completing his MD, he went on to pursue training in internal medicine and a fellowship in adult respirology, all at the University of Toronto, where he also lectures in the Division of Respirology. For the Scarborough Health Network, he has served in a number of leadership positions, including co-chair of the Corporate Medical Education Committee, hospital representative to the Toronto Academic Health Science Network Education Committee, and recently as corporate chief and medical director for the Department of Medicine. We're looking forward to an interactive session today, so we encourage you to use the chat feature to submit your questions. We'll try to address as many as we can during the Q&A at the end of the presentation. We'll also be doing some audience polling using Mentimeter, which you can access on menti.com or using this QR code. We'll also put a link in the chat. You'll be prompted to enter the code on the screen and then answer each question as it comes up. Please be sure to click submit so that your votes are counted. So a little background on this webinar's development. People living with COPD rely on emergency departments for care when experiencing acute exacerbations of this chronic disease. It is essential that we know how to provide high-quality care to optimize outcomes for this patient population. Our learning objectives for today are displayed here, and I'll give you a moment to review. And now I'll hand it over to Dr. Shulman to provide a brief overview of COPD.
Hi to everyone. The joys of modern technology. I don't know if you can see me. If you can't, you don't realize how lucky you are. It might be actually better off not to see me during this presentation. David, thank you for saying the words that I gave you so beautifully. It made me sound much better than even I thought I was, and I really appreciate that. For those of you paying attention to this talk, and I'm sure there are a few of you out there, I'm going to lay it on the line right from the start. We do not treat these patients aggressively enough, and we do not manage their discharge appropriately. And so if you're paying attention to this lecture as we're going through, you're going to end up managing these patients better acutely, but even more importantly, you're going to keep them from bouncing back to the emergency room, which was one of the most important messages of this entire presentation. So let's talk about COPD and the national statistics. A big disease. About 3 million Canadians have the disease. What's interesting is about half of them don't even know that they have it. It may even be worse. And one of the key things from Sacha's presentation is going to be how to pick up COPD in the department from patients who may not even realize they have it. And that'll be really important to know. Fourth or fifth leading cause of death, up to 79% of patients who have COPD have to limit their everyday activities because of the disease. And it's been increasing. The stats show that there's been an 82% increase from 2000 to 2013 in patients over the age of 35 who are living with it and who know they have it. Can you imagine how many more people don't even realize they have it and are forced to live with it? And obviously, when you admit these patients, they're not in and out within a day. They're staying there for anywhere from 7 to 10 days. It's expensive, and it costs the community an awful lot. Next slide, please. So the other thing that you may not realize about this disease is people with a COPD exacerbation are twice as likely to die in the year following their hospital stay as a patient who's had an MI. Now think about that. We never consider that. We think of these patients, we treat them acutely, and then we figure they're out of our hair, we don't have to deal with them again. But if you don't follow these people properly, they're at risk of dying, and it's significant. We are also Canadians, and let's just be honest, we tend not to want to bother people. We don't really involve other people in our lives as much as perhaps we should, and the stats show that. We're much less likely than the global average to get people involved, to seek health care. Now, part of that may be the fact of how tough it is to get health care. We're not going to go there, and we're not going to discuss that right now. But certainly, there's a large number of Canadians with the disease who are affected, who are going on to have serious exacerbations on a regular basis and aren't seeking necessarily the amount of care that they really need. Smoking is the predominant cause, but there are other things. And oftentimes it's an upper respiratory tract infection that triggers their exacerbation, but there could be other things. And in about a third of the cases, we cannot be identified. And that's important because if you're going to manage their acute exacerbation properly, you've got to manage the cause. And if you don't know the cause, obviously you're not going to be doing them the best you can possibly. Next slide, please. So the definition, they're sick. More cough, more shortness of breath. Enough said. Next slide, please. You have to realize, though, that severe COPD exacerbations increase the risk of death. Remember we made that statistic about the fact that you're twice as likely to die as a patient who's had an MI? If you have 2 moderate exacerbations within a year of each other, you increase the risk of death by 80%. That's very, very, very significant. And that's globally. If you look at data coming from Canada, next slide, please, you'll see that in Ontario, people are likely to die. They're likely to die as time progresses, and they're more likely to die if they're older. And these are all obvious risk factors for increasing the risk of death. But certainly, a severe COPD exacerbation increases the risk that someone will die in the next 30 to 90 to 1 year without question. And again, this is something I certainly wasn't very aware of. I managed the emergency room, I let them get discharged, and I forget about it, not realizing what else is going on here. Next slide, please. So let's look at some more national statistics. Significant cause of admission to the hospital, in fact, more than any other disease. You all know that if you're trying to examine them, it's very tough when they're very sick to figure out what's going on just based on the physical exam or their peak flows or their oxygen sat. They're not reliable. The other interesting fact is, and this comes out of a study by Ian Steele back in 2014, 38% of COPD patients presented to the emergency room are admitted by and large. But of those discharged, they're responsible for half of the adverse events. So obviously, we need to look more carefully at how we're admitting patients who are discharging, and another key message for those of you paying attention, key message is we have to be managing their discharge in a more effective manner. If you look at the COPD risk scale, the Ottawa COPD risk scale that Sacha will be talking about in a few moments, you'll notice that only 4 of the 10 items on it are directly respiratory. These people have significant comorbidities. And if you aren't managing their comorbidities along with their lung disease, you're not doing them a service. Plus, you're risking them getting a lot sicker, and you're risking them getting back into your emergency room, which is something you'd like to avoid. Next slide, please. So not only are these patients at risk for coming back, but every time they have an exacerbation, their lung function will decline. So in other words, you have the disease, you get sick, your lung function declines, I quote unquote save you in the emergency room, but your lung function doesn't come back to where it was. So every exacerbation results in irreversible lung function decline, and that only gets worse. Next slide, please. Those exacerbations accelerate the rate of further exacerbations. So no exacerbations, good for you. An exacerbation, you're more likely to have another one, and then another one, and then another one. And the period of time between those exacerbations gets diminished dramatically. The other thing that happens is all the other effects on your life, the quality of life, your comorbidities, your ability to be active and to enjoy your life, all those things go, and it's a spiral, exactly as that slide seems to indicate. It's a downward spiral, just taking you further and further and further away from a happy life. Next slide, please. So there's a reason to want to manage these exacerbations, both in terms of the quality of life and the risk of further exacerbations and maintaining lung function. And again, having an exacerbation increases not just the risk that you'll be hospitalized, but that you will die. And the numbers speak for themselves. Each exacerbation is associated with an increased risk of death. The more exacerbations, the more likely you are to die or to have something nasty happen to you. Next slide, please. So how should we manage these exacerbations in the emergency room? And you know what a COPD exacerbation is like. They come in short of breath, wheezy, miserable. And as you're standing in front of them, taking care of them, if they become more fatigued, if they become fuzzy around the edges, I believe is the polite way of putting it. But if their mental status is deteriorating, certainly if there's any degree of hemodynamic instability, you know that you're on the slippery slope and you may be losing them, and that you become even more aggressive in terms of your acute management of them. Definitely, one of the things I document is their ability to speak to me. And one of my notes says basically able to communicate in complete sentences, able to communicate only in sentences of 3 to 4 words. That's a key reproducible way of assessing the exacerbation of the illness and how sick they actually are. Obviously, if there's nasal flaring, the use of accessory muscles, they can't lie down, they're getting more and more agitated. You're all too young. But when I started in emergency medicine and dinosaurs were still stomping around the earth, patients would come in acute shortness of breath, and they were so short of breath that you could not give them oxygen. You'd be there with the mask, and they would refuse to allow you to put the mask on their faces. They were so short of breath and so uncomfortable. So lying down is just an exaggeration of that, and obviously becoming more agitated is a sign of all that. And certainly, if you get paradoxical respiratory movements, in other words, instead of the belly moving out as they breathe in and vice versa, if you get paradoxical movements, it's a sign that they're fatiguing and that their respiratory muscles are failing. These are all tip-offs that you're not doing good. You don't need a blood gas. You don't need any of this stuff. You can just look at the patient and say, this is not going in the right direction. Having said that, we cannot practice medicine in the 21st century without additional tests. So let's go on to the next slide. And so you're going to do the O2 stat, the blood pressure, and all these other things. There's an important point on that first thing, and that's about the random blood sugar. I don't know about you, but a lot of these patients are very cachectic, and they haven't been eating very well. And one of the things that may actually be contributing to where they're going is that their sugars may be very low. And I've seen both. Sugars very high because they're insulin-dependent or non-insulin-dependent diabetics and they haven't been controlled well, or the opposite situation where sugars are extremely low. And if you don't look for it, you won't pick it up. And it is one of the things that will make managing them more difficult. You all know that you don't need 100% oxygen saturation, right? You're aiming anywhere between 88 and 92%. And that's perfectly reasonable. The next point is tough. I don't know about you guys, but you've never met this person before in your life. And Dr. Death here is coming over to you, treating you, and says, you know what? You may die. Do you want me to save you? So I know that you will not be as abrupt and callous as I am, and that you will approach these patients with the proper. But I really think it's important early on to know what their preferences are, their level of care, what they really want. And I do ask them this. I said, listen, this is what we're going to do. This is what's going to happen. I need to know where you want me to go with this. If you stop breathing, do you want me to put a tube down? Do you want a machine to take it over? And I say, you don't have to tell me right now. I'm still going to do everything I need to do to save you right now. But think about how you want me to go, where you want me to go. I think it's really important that we respect the wishes of the patient, and we know what they are as we're entering into this. You'll notice the mention of an arterial blood gas. I know that we use a lot of venous blood gases to monitor these patients. I must tell you, when they're acutely sick, the venous blood gas may not be an accurate representation of what's going on. And so I always try and get at least one arterial blood gas around the same time as a venous blood gas, so I can see how close the two of them actually are and how close they are to the O2 stat that I'm picking up on my machines. And that gives me a sense of how much I can trust them and how much I can't trust them as I'm going through with taking care of them. Obviously, if they're failing, you go to invasive ventilation. I try not to tube these patients. I will do anything I can do to avoid intubating them, because weaning them off the tube is extremely difficult. Extremely difficult. And they do bad in terms of pressures, in terms of retained air trapping and all of that. They do really badly. It's very difficult. I'll do everything. I'll put them on Optiflow. I'll do BiPAP. I'll do whatever I can to avoid having to tube them. If I tube them, I try to use ketamine because it supposedly is bronchodilating, propofol as well. I use the biggest tube I can, and I try and aim for an arterial carbon dioxide close to their baseline. Not normal, their baseline. And I'm willing to tolerate a fair degree of hypercarbia if it means that I can reduce the pressures and make things easier for the machine and the ventilator, because that's going to be an issue with them. Next slide, please. So obviously you use the short-acting beta agonists, whatever you use. But there was a question early on about whether they should be by nebulizer or meter dose inhaler. The stats show there's no difference between the two. It's really a function of comfort and ease in your situation. To use a meter dose inhaler in a spacer, the patient has to be able to do it, or someone has to be able to stand beside them as they're doing it. You may not have the resources, the patient may not be able to do it, so nebulizer in those circumstances is easier. If someone is being ventilated with a machine, you cannot nebulize them. You end up having to use a meter dose inhaler, and there's the circuit that you can add on to the ventilator. So you always give them the short-acting beta agonist, and you can see the dosage there. I'm sure you have your own little treats that you do. The anticholinergic, the ipratropium bromide on a regular basis, they all get steroids. And all the studies have shown there's absolutely no difference whether you give them the steroids orally or intravenously. Certainly, if they're having trouble keeping stuff down, if they're very short of breath, if they're not feeling well, I'm not going to force them to eat something, especially if I think they may be going on to BiPAP. I don't want to fill up their stomach. I don't want them to vomit on me. So I'll tend to give it intravenously. But at the end of the day, a short course of steroids is always indicated in these patients, approximately 5 days. 50 milligrams or a milligram per kilogram, if it's a much smaller person, is a very safe and reasonable dosage. Remember to check their sugars once you put them on this. And I always put them on a PPI, because I do know that the steroids can irritate their stomach. If they're not already on a PPI, this is something that I do. In terms of the choice of antibiotics, I don't know. Really? Certainly, we almost always start them on antibiotics. We do this, even without a procalcitonin, we do this based on whatever the bugs are in our community. So we use the McGill Antibiotic Stewardship Guidelines. If they're very sick, it tends to be ceftriaxone and either doxycycline with azithromycin. I like to avoid azithromycin if there's any QT prolongation evidence or any other medications that could prolong their QT. The advantage of azithro is you can also give it IV, whereas doxy's only oral. And that's our usual regimen. If they're very sick, I put them on piperacillin tazobactam, tazocin. And that's because it covers Pseudomonas and it covers many other organisms. And those are our sickest patients, the ones who we think are really going to need admission, may even need ICU. They go immediately on that. Realize if they've been on antibiotics in the recent past, they have an increased risk of having been colonized with Pseudomonas. And that's also one of the reasons for putting them on that different spectrum of antibiotic coverage. Antivirals, you can test. You can do it on spec. Also, Tamivir, 75 milligrams twice a day, very reasonable. There is an IV formulation that I don't have access to that I have to get permission from ID for, of a different similar type of medication. But certainly if there's influenza going on in your community, or if they're at risk, or if they've not been vaccinated, or if it comes back positive, a very reasonable thing to put them on. And we have guidelines in terms of how to manage them if we think they're COVID positive. In terms of remdesivir and steroids and other treatments specifically targeted towards that. Next slide, please. So if they're admitted or they're going to be there for any period of time because they're immobilized in a bed, they need low molecular weight heparin. If they aren't responding properly, and especially if they're already on a PPI, I tend to give them magnesium unless they're in renal failure. Magnesium may have some bronchodilating effects. Almost everyone on a PPI for any period of time is hypomagnesiemic. Go tell me why. I don't know. But that's the truth of the matter. And so I tend to use a lot of it. And obviously, if they're not already on a long-acting beta agonist and a muscarinic antagonist, I will start that as part of ongoing care in the emergency room, aiming towards eventual discharge. Methylxanthines? Really? Okay, come on. I used to kill as many patients as I saved using them back in the day. Aminophylline, theophylline, no indication whatsoever in the acute management of these patients whatsoever. In fact, I'm not even sure anybody should be on them anymore, but that I'll leave up to Sacha. You may have to repeat the blood gas. You may have to do it arterially if you find that the venous isn't correlating well. You can't do spirometry or peak flows because they're too sick. They all get chest x-rays. In fact, many of them get CTPE studies, just between you and me. I have it available. It's quick. It's simple. I can check for infection, but also see if the exacerbation was triggered by a PE, which they are at risk for if they're not already on an anticoagulant. And so I often will not even do a chest x-ray. I'll go right to CTPE study. That really depends upon the environment in which you're working and what you can do under those circumstances. Definitely a CBC and electrolytes, definitely a troponin and electrocardiogram. I'm a doctor. I don't need a test to tell me if they're in failure, but many doctors in my department still use the brain natriuretic approach. That's up to you guys. And certainly CRP and procalcitonin may have a key role to play in terms of managing these patients. CRP is very helpful in terms of seeing how sick they are, just in case something subtle is going on. Procalcitonin does help differentiate whether they have a bacterial infection or something else going on. And certainly, as I mentioned, consider influenza, consider SARS. I don't know about you guys, but I'm still seeing an awful lot of COVID each and every shift. People who even vaccinated, at least 4 or 5 people per shift coming in newly diagnosed with COVID, exacerbating their situation. So I always test for it, and I'm expecting it in a lot of my patients. Next slide, please. So I now pass it on to Sacha. Sacha, thank you for being so polite and not jumping in to stifle what I've been saying. I will disappear meekly into the background now.
My pleasure, Mitch. Thank you. And folks, unfortunately, as it always happens, my headset failed, so I'm yelling into my laptop as I present this slide. So we have a patient in the emergency department. They're presenting with an acute exacerbation of COPD. The question that we now ask ourselves is, do we admit this patient? And in some centers, you'll be admitting them directly. In some centers, you'll be referring to internal medicine. We have some scoring tools that can guide this decision-making. Now, of course, this is just a scoring tool. It is a guide. At the end of the day, your clinical suspicion erring on the side of caution, recognizing how multimorbid patients with COPD are and how a COPD exacerbation can cause decompensation of other underlying chronic conditions, and recognizing that patients that we send home from the emergency department, God forbid if they come back or if they have an adverse event, the optics and the impact that that has for the patient, for the organization we work in, for the department we serve, all of this has to be weighed. But we do have a guide, the Ottawa COPD Risk Scale, OCRS. You can access this through MD Calc, and it goes through 3 domains with respect to the initial assessment in the emergency department, an element of history, an element of vital signs at presentation, so previous history of CABG, intervention for peripheral vascular disease, previous intubation for respiratory distress, of course, a very severe exacerbation of COPD, and heart rate at triage with respect to resting tachycardia at triage. Investigations that you've done in the emergency department, acute ischemic changes on ECG, element of congestion on a chest x-ray, which would be concomitant failure, anemia at baseline, which of course would lead to a high output state, may also account for that elevated heart rate at presentation, and an element of uremic dysfunction, elevated bicarbonate as a marker of CO2 retention, and frank hypoxemia. The scale on the right will add up those individual points. Your MD Calc app will be able to do the same. Overall, this will predict 30-day mortality or serious adverse events. It doesn't take much to have an increased risk from medium to high. You can look at the points on the left. You can look at the scale on the right. You check off a couple of the items on the left-hand side, of which there are 10, and you're already in a medium to high zone. That is why the lion's share of these patients are admitted to hospital, because things go wrong, and when they go wrong, better to be in an emergency department or admitted to a medical ward or an ICU than back at home. Next slide, please. We do have other assessment and prediction tools, and this is a lion's share, a list of all of those tools. I've done this so we can go through the rabbit hole and down the rabbit hole together, because some of these are going to be out of your scope in the emergency department. The gold criteria for COPD is our spirometric stratification of severity of COPD. The patient may tell you their stage of COPD because someone in my position has informed them whether they have mild, moderate, severe, or very severe disease. You may not have access to this. My EMR is a silo, your EMR is a silo, primary care's EMR is a silo. You may not have access to this. Do the best you can with respect to getting a severity from the patient. Modified MRC, though, is a good tool that you can assess at the bedside as to what their COPD burden was from a symptom perspective at baseline. There's nothing normal about this, but this is their usual degree of dyspnea. 50% of patients with COPD will be high risk with respect to dyspnea, meaning that walking around their local shopping mall at their own pace by themselves, they have to stop because of dyspnea, or they have to slow down and change their pace to avoid having to stop, or they can't keep up with an age-matched peer. That's an easy question to ask. On your own, do you have to stop? Do you have to slow down to avoid having to stop? Can you keep up with your spouse? Can you keep up with a friend of your vintage, your generation? And if the answer is no, you know that they are high risk for COPD symptoms, high risk for exacerbations. We have two additional scoring tools that you can also use. You could potentially use all three scoring tools, but the Ottawa scoring tool is very robust, and you can stick to that. 6-minute walk distance is something I do as an adult respirologist, of measuring how far a patient can walk in 6 minutes. Very nice test, because you can convert that to kilometers per hour at a treadmill pace, and it's usually the speed that they can exercise at. You probably don't have that. COPD assessment test is an 8-question, 6-point Likert scale test of COPD symptoms and the burden that it has from a respiratory standpoint: cough, sputum, dyspnea, wheezing, activities of daily living limitation. Also domains that we frequently don't ask about, and we should in the office: energy level, confidence leaving the home, quality of sleep. You may not have the opportunity. It's also not relevant per se as to how they were at home for all of those domains when they're in the emergency department with an exacerbation. But it is a tool for those that have COPD in their past medical history, not necessarily presenting with an exacerbation. Next slide, please. You've seen COPD in the emergency department. In diagnosed patients, you've likely walked by individuals and interacted with individuals and participated in their care, unknowing that they had underlying COPD. If we look at measured diagnosed COPD in Canada, males, females, middle age, older adults, the prevalence of diagnosed COPD when we actually do spirometry and measure lung function is 3 to 4-fold patients' self-reported COPD. Undiagnosed COPD exists. Patients with a current former tobacco history and respiratory symptoms present to the emergency department. They present with respiratory symptoms. They present with lower respiratory tract infections. If you have COPD, it is not just a chest cold. It is an exacerbation. It is a trajectory-altering, mortality-inducing, admission-resulting event in the life of a patient with COPD. Not knowing that they have COPD is a disservice to the patient. Recognizing the risk factors as we've discussed. Lower respiratory symptoms that are chronic. Cough, sputum, exertional intolerance. Recognizing that patients minimize those symptoms. Recognizing that they attribute them to, yeah, but I'm a smoker, but I'm a former smoker. If you have those symptoms, that's a marker of respiratory dysfunction. Recognizing this will aid detection and case finding. It is well worth the effort. Next slide, please. We are blessed with having a tool called the Canadian Lung Health Test, a very high-yield screening tool that we use in primary care to screen for COPD. Eligible patients, 40 and older. Eligible tobacco history, 10 pack years. A few cigarettes a day with coworkers over a given 35, 40-year working history, you qualify for 10 pack years. Ask them 5 questions. You usually only have to ask 3. You usually don't have to ask the last 2. Do you cough on a regular basis? Do you cough up phlegm, sputum on a regular basis? That could be just in the morning, but morning sputum, that's pathologic. Do activities of daily living, chores in your daily life make you short of breath? Do you wheeze with exertion? Do you get colds that persist longer than people you know? This is in order of prevalence. The most common symptom burden for current and former smokers with COPD is cough, sputum, and dyspnea. Fewer will wheeze. Fewer will comment on this subjective, yeah, I do get colds that last longer than people you know. If they say yes to even one of these points, lung function testing is recommended. Spirometry at a minimum with bronchodilator challenge, but do yourself a favor, order a full pulmonary function test. It has more domains of respiratory assessment that your friendly neighborhood respirologist can comment on. Next slide. It is well worth the effort. This screening tool has been validated in Montreal. In a study evaluating airflow obstruction with targeted screening, 118 out of 449 patients were identified as having COPD by spirometry. 26%. 1 in 4 had a new diagnosis of COPD, and 93% of those patients had mild or moderate disease, early disease that I love to see in my office because I can alter that future trajectory. The takeaway is that potentially a quarter of respiratory symptomatic patients with cough, sputum, and dyspnea in current and former smokers that you see in the emergency department may have COPD. Tobacco history and respiratory symptoms now presenting with a lower respiratory tract infection that is worse. It's not just a chest infection. It may be a COPD exacerbation. It is incumbent upon us to refer these patients for testing and refer to those who can help move this forward. It's not going to be us in the emergency department, but it's going to be their primary care practitioner. But hold on. Sometimes they're coming to the emergency department for a reason. In Scarborough, where access to primary care is challenging, they come to the emergency department for a reason. Oftentimes, this may have been missed in the primary care office. Internal medicine, rapid referral internal medicine clinics, your friendly neighborhood respirologist. We are very happy to see these patients because we can capture disease early in the disease course. Next slide. I'll pass it on to Mitch to look at developing safe discharge plans.
Thanks, Sacha. Look, just to remind people, there are a lot of people out there with COPD. They will present to the emergency room because they don't have access to other care. If you see them in the emergency room, 1, make the diagnosis, 2, treat them aggressively. Bronchodilators, muscarinic or anticholinergic agents, prednisone, antibiotics. And then the key thing is to come up with an intelligent discharge plan so that their exacerbation is treated and their bounce back, the risk that they'll bounce back, is reduced. So here's a situation. I have a patient who's come in for COPD, and this 72-year-old guy living on his own with chronic kidney disease and type 2 diabetes is being considered for discharge. He is able to ambulate safely and independently. He's able to eat and sleep without significant dyspnea. He's responding well to our treatment in the emergency room, but I'm still using inhaled bronchodilators every 3 hours. Hint. Okay, decide, should I discharge this patient? Yes or no? So let's look at some criteria for deciding if a patient should be discharged. And I side with those of you who said, no, I would admit them, but we'll discuss why in a few seconds. Okay, let's move on to the next slide. What are some of the criteria for discharge? Well, are they clinically stable? Sure, he was. But no parenteral therapy for 24 hours. In other words, has he been off IV steroids? Has he been off IV antibiotics for a period of 24 hours? Our friend may not have qualified for that. His inhaled bronchodilators, we're still giving him every 3 hours. That's far too often to consider it. Oxygen delivery, it has been for at least 24 hours. In other words, they're able to maintain their O2 stat without supplemental oxygen. Again, that depends upon whether they have home oxygen or not, whether it's either indicated or whether it's ongoing. If the patient was previously able to, a huge proviso, are they ambulating safely and independently? Do they get dyspnea, or does their O2 stat drop precipitously if they're up and about and moving within the room? Are they able to sleep and eat without any dyspnea or shortness of breath or drop in their O2 stat? Two really important criteria. This is the most important part of the entire presentation by Dr. Shulman. Ding, 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 ding. Okay, pay attention. One, does the patient understand and are they able to follow through with their medication? When was the last time you watched one of your patients actually self-administer their bronchodilators using a spacer or not? Do they do it right? Do they understand how to do it? One of the major causes of exacerbations, the major causes of bounce back, is the failure of patients to be able to administer their discharge therapy appropriately. Through no fault of their own if you're not helping them and not checking. Number one. Number two, follow-up. Follow-up on these patients is so important. Study after study has shown that if you don't put in place some sort of automatic follow-up home care plan, these patients will bounce back. And the speed with which they need to be contacted, whether by phone or in person, is a function of how severe their exacerbation was. So before you discharge them, do they understand? Does their caregiver understand your plan? Are they able to administer their medications on their own? And is there everything set up to optimize their success at home in terms of Meals on Wheels, nursing, and follow-up? Next slide, please. So if they're not responding to therapy, duh. If they are becoming sicker, cyanosed, altered mental status, certainly if the intensity of the symptoms are getting worse and haven't returned to baseline, certainly if they're in respiratory distress, certainly if they have significant comorbidities. The patient who comes in with COPD exacerbations, but their troponins are elevated, maybe not in the range of necessarily an MI, but in what the cardiologists delightfully call demand ischemia, I'm not sending them home until things have stabilized and their troponins are coming down and their EKG is good and they're not tachycardic. So that in itself may be a reason for admitting them. And obviously, if there's insufficient home support, you're going to have to bring them in for a period of time so you can set things up at home and in their community. Next slide, please. So if you discharge them, have a specific, intelligent, well thought out plan and make sure that they're able to follow through with it. So they should be on inhaled therapy. And as Sacha will go into in more detail, we're now realizing that just putting them on a long-acting beta-2 agonist, just putting them on a receptor antagonist, a muscarinic receptor antagonist, and an inhaled corticosteroid, you've got to put them on all three. And there are now products available on the market, inhalers, which combine all three medications. Almost no one with a significant exacerbation of disease should be leaving your department without that type of therapy on board. And I'll leave it to Sacha to go into the details behind that a lot more. They all should get 5 days of oral corticosteroids, prednisone or equivalent for 5 days. And obviously, their antibiotics should continue oral, and you have your choice of oral antibiotics. Make certain there's follow-up. And if necessary, if they're severe, someone is calling them or checking up on them within a month. Someone else, if they're not so severe, is checking up on them within 3 months. Now, I don't know about you guys, but getting access to a family physician is almost impossible for a lot of my patients, a lot of the patients I see in the emergency room. Some of you have the advantage of follow-up clinics that work through your emergency room. Take advantage of that. Some of you have the advantage of a day hospital run by respirology. Take advantage of that. And if the respirologists are all as nice as Sacha and they're willing to see these patients, yes, refer, especially if they don't have a respirologist seeing them on a regular basis. Obviously, their vaccination status should be brought up to speed. Someone should be checking their technique before we allow them to be discharged. There's a beautiful study in the American Journal of Health Sciences looking at the use of pharmacists in the community to monitor the adherence to therapy and their ability to take care of themselves properly using their inhalers, showing that pharmacists in your community can play a key role in keeping these patients out of the emergency room and making certain that they're able to use their bronchodilators, their inhalers properly. Pulmonary rehabilitation is always something to consider to get them back. And of course, home care and some sort of help at home, especially if they're on their own, as our index case that we were referring to, our 72-year-old male was living on his own. I'm going to make sure that someone's looking in on him on a regular basis for the next little while. I may even reach out to the family. I've been known to do that. Your dad's in the emergency room. He's told me to get in touch with you. I just want to make sure someone looks in on him in the next couple of days, make certain he's okay. Next slide, please. And so we will now turn the ball over to you, Sacha. Take it.
Wonderful. Thank you. So, colleagues, when we're looking at optimizing pharmacologic therapy for prevention of exacerbations, I'm going to start with sort of two golden rules. Like most things in life, the best indicator of future behavior is past behavior. And if we do not optimize and adjust controller therapy in the emergency department, the event that has occurred, the exacerbation, is likely to occur again. When we look at patients with a history of COPD exacerbations and delayed maintenance therapy, we see an increased risk of subsequent exacerbations. Patients are at greatest risk for exacerbations. Who are they? Those who've had exacerbations in the past. On the x-axis below, those with respect to none, one, or two or more exacerbations, moderate or severe in the previous year, and the prevalence of repeat exacerbation, none or one or more. We see an increased likelihood of exacerbations for those who have had events. On the right-hand side, if we delay maintenance therapy after a severe exacerbation, we have an increased risk of a future event. 70% increased risk of a moderate or severe event, 80% increased risk of a severe exacerbation. And what kills patients from severe exacerbations is respiratory, but also a sizable proportion, as we'll see in future slides, that is cardiac related. Next slide, please. This is the second leading cause of hospitalization in Canada after childbirth. It's the second leading cause of hospitalization after propagation of our very species. Most patients with COPD have exacerbations. They have a significant impact on quality of life. The impact goes beyond the lungs, increasing the risk of fatal and non-fatal cardiac complications. This is actually one of the reasons why I have a practice 2 days a week in a group of cardiologists, in the office actually, literally in the office of a group of 12 cardiologists, seeing their internal cardiac patients, because there is a huge degree of comorbid overlap and improvement of adverse cardiac outcomes when COPD is optimized. Prior exacerbations, exertional dyspnea, elevated blood eosinophils, which we can touch on in the Q&A, but I'll show you our new guidelines, which really addresses the risk factor that comes from elevated eosinophils with respect to exacerbations. All of this leads to increased progression, risk of cardiovascular events, and death. Preventing exacerbations is key. Next slide. So we've talked about this. There's an element of inflammation in the setting of COPD. Inhaled corticosteroid does reduce inflammation in the lung. There is a systemic anti-inflammatory effect of inhaled steroid that plays a role in reducing the adverse outcomes associated with comorbid cardiac disease. There's also an element of hyperinflation, and dual bronchodilator therapy maximizes lung size, maximizes airway caliber, minimizes hyperinflation, maximizes lung function that the patient can use. For those with concomitant heart failure, if you deflate the lung, you improve the ability of the lung to hold blood. You actually improve right ventricular ejection function. You improve left ventricular output as well. You have significant improvement in cardiac outcomes from heart failure when you deflate the lung. Combine ICS and bronchodilators, we actually see better ventilation perfusion matching, less hypoxemia. Next slide, please. There is an opportunity that occurs early to initiate single inhaler triple therapy. And I'm introducing this concept early before I show you the guidelines. For patients presenting to the emergency department with an exacerbation of COPD, ED doors, hospital ward, or ICU, The beginning and end for pharmacologic therapy is now single inhaler triple therapy. Prompt initiation within 30 days reduces the likelihood of all-cause readmission, reduces the likelihood of COPD-related admission. My comment to primary care colleagues is when you get that notification from the ED that they were there for a COPD exacerbation or the discharge summary from the hospital ward, where is the triple therapy? It should have been started in hospital. Pharmacists should have educated the patient on it in hospital. Someone in my position hopefully has been following as a consultant and is taking over that patient's care as an outpatient. But prompt initiation lowers the likelihood of all-cause and COPD-related readmission. They value the hospital. They look at it with respect. When we make changes in the hospital, they follow it. Our primary care colleagues as well. People respect us and what we do. And when we make a change to prevent this from happening again, they will follow it. And we're rewarded. Prompt trumps delayed. Next slide. If we want to look at exacerbations with prompt initiation of triple therapy versus delayed initiation of triple therapy, there is a huge 43% relative reduction of repeat severe exacerbation with prompt initiation. This was a real-world study with retrospective data from the US and the UK. It looked at Trelegy single inhaler triple therapy and reduction of exacerbations. Less likely to be readmitted for COPD or all-cause readmission, less likely to have an exacerbation. Next slide. This is our new, streamlined, and very up-to-date randomized control trial-based COPD pharmacotherapy guideline from the Canadian Thoracic Society. I could spend an hour talking on this alone, but I'm going to turn the attention to the box in red. I've added the box in red to highlight the patients that you are seeing in day-to-day practice. Patients that present to the emergency department, by definition, have had a severe exacerbation. ED doors, hospital ward, or ICU, it is severe. High-risk patients are those with 2 or more moderate exacerbations in the previous year, something that was treated in primary care office, my office, but it was treated as an outpatient. A severe exacerbation is an exacerbation that takes place within the confines of our hospital. Regardless of how symptomatic or asymptomatic you are, how mild, moderate, or severe your COPD is. Our guidelines are designed that the worst outcome for the patient trumps. If you have a severe exacerbation, the beginning and end of pharmacotherapy is triple therapy, LAMA, LABA, ICS. The controller therapy that you will change that patient to is LAMA, LABA, ICS in a single inhaler. I value this. I will greatly applaud this, and I love it when I receive a notification from the emergency department, patient with COPD presenting with their first severe exacerbation. I started them on triple therapy. Start the patient on the medication. I know this is a challenge, but you can complete a prescription for that single inhaler triple therapy. You can identify to the pharmacist that I saw them in the context of the emergency department. This should be continued by their primary care physician or the respirologist that I'm referring to. When I realize that that patient has a 1, 2, or 3 month supply of medication from you, I know the urgency that I have to see that patient is driven by the severity of the exacerbation and the fact that they'll run out of medication. But it is incumbent upon us to do it, because if we don't do it at the time of admission to hospital, time of walking through the walls of the institution that we serve and the community we serve, that patient is ticking to have an increased risk of this event happening again. On the left-hand side, there are those with low acute exacerbation of COPD risk. We'll spend a minute here. There are patients that you will see in the emergency department that have COPD listed in their past medical history, but they're not on anything for it, or what they're on may be insufficient in the modern era. For symptomatic COPD, patients with exertional dyspnea, of which over 50% will be in that high-risk modified MRC class 2 that we had discussed earlier. The minimum therapy for them is dual bronchodilator. 2 bronchodilators together in a single inhaler. Next slide, please. There are 63 inhalers in the province of Ontario, 63 inhalers across the country approved by Health Canada. It'll be 67 by the end of next year. For triple therapy, you only have to remember 2. Trelegy 100, for those in Ontario, it has a limited use code, and Breztri, There's no number beside it. There's only one inhaler, Breztri. 2 inhalers that you have to know. Escalate these patients to single inhaler triple therapy with Trelegy 100 or Breztri. For those on the left-hand side who have not had a severe exacerbation but have symptomatic COPD, one of these 4 dual bronchodilators is the minimum. Pick your favorite. By popularity and by clinical trial evidence, Anoro, Ultibro, and Inspiolto are the top 3. Duoclear doesn't have a clinical trial as a dual bronchodilator showing improvement of heart outcomes, but Anoro, Ultibro, and Inspiolto do. Focusing on the presentation today, on the right-hand side, Trelegy and Breztri. Next slide, please. A COPD exacerbation in the ED is a severe exacerbation. The standard of care is single inhaler triple therapy. Prompt initiation of triple is superior to delayed initiation. Single inhaler is preferred from an adherence standpoint. 1 is better than 2 or 3 inhalers. Primary care practitioners value your concerns. If you comment on query COPD, trust me, they will pursue it with testing. If it's on their past medical history and they're not on dual bronchodilator therapy and you escalate, they will value that, they will continue it. If you escalate to triple therapy, they will respect it, they will continue it. If you don't mention it, they may not pursue it either. Remember that there's a significant value from the patient placed on what we do in hospital, and they look at the comprehensive care team, triage nurse, bedside nurse, other individuals on the care team who they may not recognize who exactly they are. Sometimes they think that they're all physicians, but patients value what we do. If we don't comment on it, they may not think that it's actually a concern. If we don't mention it in our notes, PCPs may not think that it's worthwhile pursuing. People place high value on what we do. If we don't address it or investigate it, it may not be pursued. And medications that we change in hospital, rarely is that reverted or regressed as an outpatient. They value our opinion, they value our assessment. Next slide, please. Looking at impact of comorbidities, COPD does not exist in isolation. COPD exists with a multitude of comorbidities. The unifying factor here is combustion byproducts, be it tobacco smoke, ambient air pollution, occupational exposure. Common culprits. Cardiac comorbidities are a major driver. Here, the prevalence of individual comorbidities is based on the size of the disc. Hyperlipidemia, coronary artery disease, congestive heart failure, hypertension, major drivers. Also on the left-hand side, metabolic disease, diabetes, degenerative joint disease as well, which of course comes with muscle deconditioning, sarcopenia, muscle wasting, and increased load placed on those joints. Next slide, please. When we're looking at some mechanisms of COPD-driven cardiopulmonary risk, there is an element of inflammation that can destabilize plaque. There is an element of hyperinflation that can compromise cardiac output and hinder blood pumping through the lungs and to the rest of the body with respect to impinging on the left ventricle. And there's also an element of hypoxemic vasoconstriction and pulmonary hypertension, which leads to right heart failure, decreased right ventricular function, and of course, the right ventricle shares a septum with the left ventricle, decreased left ventricular output. All of this combined, when you have an exacerbation, it's an acute explosion of inflammation that results in a stepwise decline of each of these 3 respiratory factors, leading to worsening cardiac outcomes. Next slide. There is a shared risk factor and impact of exacerbations. The key element in the middle, highlighted in red, is hyperinflation, hypoxemia, and systemic inflammation. That drives the adverse outcome. The shared risk factor of smoking causes COPD and cardiac disease. That's why I have a practice with a group of cardiologists. You have patients with established ischemic, arrhythmic, and mechanical cardiac disease with a 30-pack-year tobacco history. Guess what? They also have concomitant COPD, and when I treat their COPD and prevent exacerbations, I reduce the likelihood of fatal and non-fatal cardiac events. My cardiology colleagues love it because they work hard to keep patients alive from a cardiac perspective. And the lungs, the organ that cushions the heart, so to speak, if we miss it, we're going to miss a big risk factor for cardiac disease. Next slide. When we're looking at impact of COPD, having that exacerbation increases the risk of vascular events. After a moderate outpatient exacerbation, 2-fold increased risk of MI within the next 5 days, 40% increased risk of stroke. What you don't want to miss is sending that patient home with unstable cardiac risk factors and respiratory risk factors, and God forbid they come back with a stroke or an MI. Stroke is catastrophic. Of the many things that I fear in life and lead to anxiety for myself, stroke is up on the top 5 of that list. On the right-hand side, the risk of fatal and non-fatal cardiac events persists for up to a year after an exacerbation. Fourfold risk in the first 30 days, 90% increased risk for the rest of the year. It doesn't go away after the event. An explosion of inflammation occurs. Next slide. Cardiovascular disease is a common cause of death in COPD, not just in severe disease, but also in moderate. This is why early capture is key. On the left-hand side, up to 40% of COPD deaths in these 5 studies was due to cardiac causes. And on the right-hand side, this is the shocking part. Severe COPD, FEV1 less than 50%. Third of patients die of respiratory-related morbidity and mortality. Respiratory is the lion's share cause of death. But in moderate disease, in early COPD, lung malignancy, which is uniform across the board, and cardiac disease are the leading causes of death. If we miss early COPD, we are missing cardiac-related causes of death. We're missing preventable mortality. We need to capture these patients early. We need to screen and ask the question. Next slide. When we're looking at cardiac comorbidities in patients with COPD and the risk of death, if you add COPD to a present cardiac comorbidity, you worsen outcomes. Up to 50% increased risk of fatal and non-fatal events and mortality specifically here in ischemic heart disease. Up to 70% with diabetes, up to 90% with heart failure, 60% with atrial fibrillation. Heart disease plus COPD is worse than heart disease alone. Optimizing that COPD reduces that risk, but you got to look for it. Next slide. Again, hammering home the point, here on the left-hand side, we're looking at comorbidities and an increased risk of hospitalization. The more conditions the patient carries, regardless of severity of COPD, GOLD 1 through GOLD 4, greater the likelihood that they're going to be hospitalized. And on the right-hand side, those that have cardiovascular disease, more likely to be hospitalized as well. Comorbid COPD, more likely to wind up in the ED, more likely to be hospitalized, more likely to die. Next slide. This is a vicious cycle, and I implore you to take this to heart because patients with COPD acclimatize to a degree of disability. This is an insidious disease that robs them of their livelihood, robs them of their activity, robs them of their identity. And it happens so slowly in some that they acclimatize to it. This is my lot in life. This is what I have to live with. It doesn't have to be this way. But when an exacerbation occurs, it accelerates decline in lung function, fatal and non-fatal cardiovascular events, decline of physical activity and deconditioning, decline of mental health when you cannot do what you used to be able to do just a few months ago. Increases the risk of future exacerbations, all of this leading to death. It's not just enough to say, how's your breathing? What do you have to do to become short of breath? What is it that you used to be able to do? What is it that you want to do, have to do, would like to do that you can't because of dyspnea? Ask those 3 questions. You'll often get 3 different answers. Ask, how's your breathing? It's fine, but it really isn't. Next slide. Key messages. This goes beyond the lungs. Effective treatment of COPD in the emergency department is aggressive. It is multifactorial. It is prompt. You will treat the exacerbation with prednisone. You will treat with antibiotics when it's an infectious exacerbation, and they're by and large infectious. You will discharge that patient on single inhaler triple therapy, because if we do not optimize controller therapy at the point of the exacerbation, the patient may think this is just another chest infection, and I get these chest infections. What they don't realize is that they are playing Russian roulette with a bullet that is ever powerful. They will have to have prompt initiation to alter that trajectory. Ongoing care is key. This has to be a well thought out, explained management plan. Rely on internal medicine, rely on rapid referral clinics, rely on respirology. Smoking cessation is there. Vaccination is key. Home support, all of the things that we've talked about. Ideally, this is a multifaceted team, but it starts in the emergency department with recognizing the exacerbation. It starts with treating it, escalating to triple therapy. It also starts upstream of that exacerbation before that patient comes back with a chest infection who may have COPD, capturing that patient early. Next slide. Colleagues, I apologize. We don't have much time for questions, but thank you for paying attention to this.
All right, thank you very much for that excellent and informative presentation. We're getting a few questions now from the audience, so I'll jump right in. So for a patient that is already on appropriate maintenance inhalers, say triple therapy, and they're still having exacerbations, would you recommend that we wait for a resp consult before starting things like macrolides, mucolytics, or PDE4 inhibitors?
That's a great, great question. So, of those three, things that we can do from a respiratory perspective, in addition to referring these patients for pulmonary rehabilitation, we may also realize that some of these patients are eligible for lung transplant assessment. So that's where Friendly Neighborhood Respirologist is able to assist. These patients with recurrent exacerbation should also be assessed for exertional hypoxemia, in addition to resting hypoxemia with a home oxygen assessment. Specifically, to answer that question, mucolytic therapy with N-acetylcysteine, generally 1,000 to 1,200 milligrams a day, you please feel free to start that. That has virtually absence of any adverse effect. They can purchase it online at Amazon or at a health food store. Please go ahead and start that mucolytic therapy. Also, mechanical chest physiotherapy with Aerobica. It is a device that provides mechanical chest physiotherapy, liberates secretions, clears the airway, best utilized 10 minutes 3 times a day. Those two, very happy for you to start. Happy to also start Daxis as well, as long as you caution the patient. Most common adverse effect is going to be gastrointestinal. Upset stomach, some dietary intolerance, mainly diarrhea. If they start that medication at half a pill a day for the first month, then 1 pill a day ongoing, Daxis is generally well tolerated. Mucolytic with N-acetylcysteine, mechanical chest physiotherapy with Aerobica, Daxis, very fair to start. Leave azithromycin, please, to your Friendly Neighborhood Respirologist. The challenge is, if they're colonized with Mycobacterium avium, it will lead to resistance. And if that patient goes on to develop Mycobacterium avium disease, the key drug azithromycin that we use to treat that, in addition to rifampin and ethambutol, we've lost. And the second line therapy is injectable drugs, which have terrible side effects. So we need to counsel them appropriately as to if they are colonized with it. Please do not attempt to order AFB times 3 in the emergency department. That's a good way for IPAC to come down and to put that patient on airborne isolation and lead to a mess in the emergency department. So leave that to us.
Perfect. Another couple of questions that are quite similar to each other, so I'll put them together. So again, for a patient that's on optimized maintenance therapy with triple therapy, what's the role of short-acting beta agonists and short-acting anticholinergics in the short term and in the medium term, the long term as well?
So in the context of a COPD exacerbation, cholinergic receptor number and density doesn't change. If someone is on triple therapy, which has ICS, LABA, or LAMA, but even if someone is on dual bronchodilator therapy with LABA and LAMA, and they're reliably able to take the dose, even in the context of an exacerbation, you could forgo Atrovent. The short-acting muscarinic antagonist will lead to adverse effects because a long-acting muscarinic antagonist binds very strongly to receptors. So why do we use it in the setting of an exacerbation? Most of the time in the setting of an exacerbation, the patient can't get the full dose in, and we're not confident that they're getting their triple therapy controller or minimum dual bronchodilator therapy controller into the chest. We add Atrovent on. That is the first thing that I look to discontinue once I can confirm that the exacerbation is treated, they're able to take their long-acting controller therapy without issue. However, beta receptors increase in number and increase in density during exacerbations. Patients become more beta responsive. We can be very liberal with respect to nebulized and MDI use of Ventolin. I have no concerns with that because patients will have variation between patients as to how much beta responsive they are. The logic is also the same. They may not be getting the full dose of their controller. You need to supplement that with Ventolin. Atrovent, however, please only in the short term, because you could make that chest congestion far more sticky, tenacious, difficult for the patient to expectorate if you continue to dry up those secretions.
Excellent. There's anyone else with questions, feel free to put them into the chat right now. just a question that I thought of as you were speaking there. So, if somebody is on triple therapy through two inhalers and they're in the emergency department for an alternative reason, kind of not necessarily in the context of an exacerbation, do you think it would still be an opportunity to move them to triple therapy through a single inhaler?
Yes, please. The reality is, look, I'll give my own example. I take 9 pills a day from 5 different medications. I forget. It happens to the best of us. We know that older individuals with COPD, there are differences with respect to inhaler frequency, inhaler technique, and compliance varies. Our patients sometimes do not know the purpose of each individual inhaler. They may opt for one versus another. Life circumstances get in the way, and it's hard to take 2 inhalers or more multiple times a day. The data for asthmatics, generally a younger cohort, demonstrates superior outcomes for lung function, exacerbations, and symptom control for 1 inhaler versus 2. We have data from the Intrepid study and the Spanish study looking at outcomes in COPD, showing once a day therapy with 1 inhaler superior to multiple inhalers. Please take the opportunity to consolidate. The patient will thank you. There is never a moment where patients say, wow, I really prefer to be on more medications. They will gladly thank you for that.
Perfect. Maybe one last question. You mentioned earlier that you were going to touch on the patient with elevated eosinophils.
Yes. So there is a marker for elevated eosinophils in patients with COPD, where an eosinophil count in the CBC of 0.3 or higher places the patient at increased risk of exacerbations. It's a nice finding to see that indicates that the patient is at increased risk of exacerbation. But for the purposes of those working in the emergency department, it doesn't change what you do, because a patient presenting to the emergency department with an exacerbation warrants escalation to triple therapy. Even if that patient had an elevated eosinophil count of 0.3 or 0.4, you are still going to escalate them to triple therapy. For those of you who may work in an outpatient setting and you have a patient with COPD on dual bronchodilator and the CBC shows an eosinophil count of 0.3, take note of that. That eosinophil count of 0.3 on a dual bronchodilator is a marker of an increased risk of exacerbation. Escalating that patient to triple therapy does them a service, because that 0.3 or higher places them at increased risk. But for the ED, doesn't change what you do, because our guidelines now aggressively place triple therapy as the first and last treatment for that patient, inhaled-wise. You're going to do it anyways. Trelegy 100 or Breztri is that escalation.
Okay, we got a couple more actually. So, GOLD guidelines still mention de-escalation of ICS based on phenotype and eosinophilia. Is that no longer recommended?
That is correct. It is no longer recommended. The data from the CTS looked at, and again, the CTS is a guideline that is evidence-based of randomized controlled trials. We know from IMPACT and ETHOS, 2 of the largest respiratory trials, that for patients with an exacerbating phenotype, within those 2 studies, those who were on dual bronchodilator therapy with an exacerbating phenotype had an increased risk of exacerbations compared to those on triple. But the middle part of our algorithm has also changed. We no longer have a de-escalation. This comes from the Chronos study. The Chronos study took patients with a history of COPD, 74% of whom in the previous year had not had an exacerbation. They were exacerbation-free. Those who were de-escalated from triple to dual bronchodilator had a doubling of the rate of exacerbation. The data from Chronos guides us that if we have a patient on triple for the right reason, because I escalate to triple frequently in my practice, and sometimes the phenotype changes. They become exacerbation-free. I escalated to them to triple for the right reason. De-escalation would be a disservice to that patient. Where this comes about, new clinical trials that captured a different patient population. Some of the older studies looked at patients where not all patients had a history of exacerbations coming into the study. But if you take patients with a history of exacerbations, they're escalated to triple, they stop exacerbating, and we de-escalate, the exacerbations come back. No more de-escalation.
Got it. The questions keep rolling in there, so I'll go to the next one. This is to do with intubation. So there was a note of respiratory rate of 10 to 12 per minute when intubating the patient and setting up the vent. What are your thoughts on trying to match the respiratory rate pre-intubation while maintaining low tidal volume ventilation.
As a respirologist who doesn't practice intensive care medicine and relies on the RT for the vents, I'm going to have to actually pull Mitch into this to address this question.
So basically, you titrate your rate to the response of the patient, and that's why you repeat the gases to see exactly where they're going. So I'm not set at any number. I'm set at what the patient's response rate is like. And so I don't aim for where they were before. I don't aim for matching the respiratory rate previously. What I try and do is I try and maximize the calming effects of what I'm doing. The propofol is the continuous drip, the ketamine perhaps as well, or ketofol, putting both together. And the idea being that I put them at a rate and at a pressure so that I minimize the barotrauma that I'm trying to do. But I count on RT to help me with this because it's a very sophisticated and difficult thing. Intensive care and RT are essential to manage this properly.
Awesome. And I think this will be the last question. So in which severity of patients are you using magnesium IV? Just severe or for moderate also?
I tend to use magnesium in almost all my patients who come in who need more than a few hours of treatment. So if you're staying in the emergency room for any period of time, I almost always do a magnesium level on you. Most of them are deficient, and I almost always give them at least 2 grams over the next 2 hours, 5 grams if they're severely deficient, or the next 5 hours. I certainly find it to be a useful tool, and I do think that it may make a difference. Certainly, rhythm control is also an important consideration in this setting. And I don't want them to become hypomagnesiemic in terms of trying to control their rhythm as well.
Excellent. Well, thank you to our presenters for this excellent talk. We have now some very useful pearls and tips for the next time we're caring for someone with a COPD exacerbation. I'd also like to thank everyone else who joined in today, the Scientific Planning Committee for their valuable input, the CAPE staff team for the work behind the scenes, and our IT support team. This session has been accredited by the College of Family Physicians of Canada and the Royal College. Please don't forget to complete your evaluation form and claim your credits. A certificate of attendance will be mailed out by CAPE together with the evaluation link. Finally, CAPE has a very interesting lineup of live, on-demand educational webinars planned over the next few months. So please keep an eye out for more information and plan to join us again soon. Thank you again.
Bye, everybody, and thank you.